Good morning, good afternoon, everybody. I'm Mark Waxman, a partner with Foley and Lardner's healthcare practice, and I would like to welcome you to the Foley and Lardner Oliver Wyman co-hosted Health Market 2.0 Provider Plus Innovators, the new catalyst to our health webinar today. This is another in our series of explorations of the changing healthcare market. We previously have talked about such things as payer-provider relationships, alternative delivery sites, and so forth. And today we're going to be focusing on the relationship between providers and innovators. We've got a terrific series of speakers today for us for this program, and let me first introduce them now. First, Frank Williams, the Chief Executive Officer from Evolent. Jan Berger, Dr. Berger is the Chief Clinical Strategist at Quantum Health. Dr. Sanjay Shetty from the Steward Health Network, President of the Steward Health Network of the Steward System. Jeff Miklos, Executive Director of the Transformation Task Force, and I'll be joined today by Sam Glipp of Oliver Wyman. And so before we start, let me go over a few household tips. We're on for 90 minutes. We're going to apply for 1.5 general CLE credits for today's program. For those of you interested in CLE, listen carefully for the code, and when asked the polling question, let's make sure that we get it right. All New York, New Jersey, Kansas attendees applying for CLE credit must also fill out an attorney affirmation form, which can be found in the resource list widget. Electronic questions we invite to be submitted by clicking the Q&A tab at the bottom of your screen, and hopefully we'll answer the questions as part of our discussion or at the end of the broadcast, or if for whatever reason we don't do that, we'll try to get back to you after that's over. The emphasis of our program format is on a discussion flow. So we'll start with our speakers introducing their companies, and then we'll lead into a discussion of a series of questions rather than sort of the standard long PowerPoint. So I think that works out pretty well. Let me first start by going with Frank Williams, Chief Executive Officer of Evolent. And Frank, maybe you can talk a little bit about Evolent and your role, and we'll go on from there. Frank?
Great. Well, thanks for having me participate today. I love these kinds of sessions and look forward to a good discussion. We started Evolent about 4 years ago, largely from feedback we had from providers that were trying to navigate the transition to value-based care, and really felt that they needed broad-based support, both in terms of how do you actually, get lives under risk-based arrangements, and then once you have them, how do you actually create value through clinical transformation, and a feeling that they needed broad-based integrated support to help them in that journey. So really our vision is to build a national network of leading providers that want to move aggressively to value-based care initiatives and likely across many populations. We ultimately provide technology that initially came from UPMC, which is a very large provider payer, providing clinical knowledge, and then wrapping that with people and services to enable people to do anything that they need to do, whether that's starting a new Medicare Advantage plan, taking delegated risk from a payer, integrating their physicians in a new model. Those are all things that we try to provide through our platform and people. And then we do think we're a little bit different in approach in terms of a belief that it really is provider-driven care that's going to ultimately make a difference in improving outcomes and clinical costs. So how do you really engage the physicians and build integrated care teams around them? How do you make sure the platform is truly integrated, because you do see that benefit of bringing together clinical and financial with the leading organizations in the country, that you're able to build infrastructure that can be applied to multiple payers so that it's scalable, and then ultimately that you really are driving proven clinical and financial results. And so we're in roughly 25 markets today, working with a number of leading organizations, and again, learning a lot and applying that experience in some early good clinical results, and excited about where we are. So that's a little update on Evolent.
Appreciate it, Frank. Let me now go on to our next up is Jan Berger. Dr. Berger.
Thank you. And you may want to click the animation on this just so everybody can see all the part of the slide there. Hi, I'm Jan Berger, and I am the Chief Clinical Strategist for Quantum Health. We're based in Columbus, Ohio, and Quantum is a leader in care coordination and consumer navigation. And you may wonder, why is a consumer navigation company as part of this conversation? And I hope in a minute you'll understand why. We're hearing more and more about care coordination in the healthcare environment recently, and the topic comes up and the services are discussed. Quantum is unique in a number of ways. First of all, although the conversation is new, this company is not. We've been in place since 1999, so for 16 years. And the founder, Kara Trott, started the company after doing a bunch of research and talking to 3,200 consumers and 290 physicians. So she did not take it in a single stakeholder model. And what we found was that no one goes through their healthcare journey, which is an unchosen journey, without getting stuck. And any of you on the phone, if you are a family member, has gone through a healthcare event, you know it is a journey. And interestingly, the average consumer makes 41 major decisions through this one journey to get to their new normal. But even more interesting, over 95% of these decisions are outside the usual scope of medical practice. I trained as a physician, and most of the things that we hear from the healthcare consumer are things that I got to tell you I wasn't trained to do, and my physician office when I practiced wasn't in a position to easily do. So what Quantum does is take much of that burden off the consumer by working with the consumer and their family and caregivers, but uniquely to our company compared to most care coordination and consumer navigation companies, we are unique because we work with the providers as well. We become the single point of contact for the consumer and the providers. Can you imagine only having to call one single number instead of, if you're on the phone and you are a provider, you probably sit here and say, I am so frustrated because I can't figure out what phone number to call to get for my patient what they need. So we really work with the consumer and the provider. And we do this on behalf of a large number of employers in the country. And one of the things you'll hear during this upcoming conversation between all of us is that the providers have come to us and said, thank you. You allow us to do what we need to do each day, which is care for the patient, and the stuff we hate to do is taken off our hands. So that's who Quantum is. Thank you.
Great. Thank you very much. Much appreciated. Next up, we'll talk to Dr. Berger from Steward Health. Dr. Berger?
Actually, this is Sanjay Shetty from Steward Health.
Oh, I'm sorry, Sanjay Shetty. My mistake.
No problem. Thanks, everyone, and thanks for allowing me to participate in the call. My name is Sanjay Shetty. I'm the president of Steward Healthcare Network. For those of you who aren't familiar with us, we very much are a provider right now in the trenches working in the world of value-based care. Steward Healthcare System is an integrated delivery system, the largest community-based health system in New England. A little bit about us. We have 9 hospitals, over 10 campuses, about 25% of the acute hospital beds in eastern Massachusetts, with a physician network that's about 3,000 physicians, including both employed and private practice physicians. What makes us a little different, I think, than many community-based providers that are out there is that we have gone full-fledged into the world of value-based care. We have over 300,000 managed risk lives across an array of commercial and governmental contracts, primarily on the governmental side, focused on the Medicare space with Medicare Advantage, the ACOs. We were previously a pioneer, are now contemplating the entry into Next Generation in 2016, as well as in the bundled payments program. On the commercial side, through a number of commercial contracts across the 3 major payers in the state, as well as with managed Medicaid. So our system really is trying to make the value-based paradigm work in practice and working between sort of that integrated system to try to deliver care that's coordinated at sort of the lowest cost, most appropriate site for each of our patients. Thanks.
All right, Dr. Shetty, thank you very much. And now let me turn to Jeff Miklos from the Healthcare Transformation Task Force.
Thanks, Mark, and good afternoon, everybody. It's a wonderful opportunity to be part of this esteemed panel, and I am the Executive Director of the Healthcare Transformation Task Force, and the task force has just passed its first birthday and is a consortium of payers, providers, patients, and purchasers that have all come together with the single goal of transforming their systems to value-based arrangements. To be a member of our task force, you need to commit to a 75% of all of your business activities in alternative payment model contracts by 2020. It's an exciting time to be part of this. Certainly, we're showing you on the slide here our members. We started off with 29 members when we publicly announced in January of 2015. We currently stand at 41 members of people who are like-minded and committed to moving forward, but also making sure that the payer, provider, purchaser, and patient voices are all combined together. Mark, next slide. Our focus is really to produce products in the area of best practices and toolkits. We've also been responsive to policy making at the federal level, but our guiding principles really outline what we believe is a financially and operationally viable and sustainable approach. Again, our focus of shifting 75% of our businesses to value-based contracts by 2020, and designing programs that provide reasonable returns and deliver the triple aims, but still allow for investment in infrastructure and care delivery systems that are innovative. We encourage multi-payer participation and alignment so that we create common targets, metrics, and incentives. Obviously very challenging, but something very important to the success of value-based contract arrangements. I think it's important that we do make sure that the cost savings are shared across the spectrum to ensure adequate investments in new care models. How do you run your existing business while you're transitioning is one of the biggest challenges our members face, something that we try to help them with as we go forward. And of course, we're fostering transparency of the quality and the cost metrics in a manner that's accessible to and easily understood by consumers. I've joined the organization a short time ago, and one of the real refreshing things, which I believe Dr. Berger would agree with, is the idea of having patient voice in the design of your programs on the front end. Patient engagement, as it's been commonly referred to, simply isn't sufficient when you're looking for the input necessary to care for a population in a particular market. And of course, at the end, we'll say we support the needs of disadvantaged populations and help strengthen the safety net providers who serve them. We certainly are focused on what's happening in the private sector, understanding that more and how that can translate to programs that are really being implemented at the federal level. And with that, Mark, I'll turn it back to you.
Okay, thanks, Jeff. Much appreciated. A pretty broad spectrum of industry involvement. And with that, let me turn it over to Sam and for some sort of overview remarks.
Thanks, Mark, and happy to set the stage for our conversation today, and delighted to have the guests that we have. I think we have a great perspective on where the industry's been and where the industry's headed. One of the things as we were bringing this group together that I think we all talked about emphasizing is that innovation has been a buzzword across industries, but especially in healthcare for a long time. But the kind of innovation that we're seeing now and that we want to discuss today is qualitatively different than what we were seeing even just a handful of years ago. If you kind of x-rayed the innovation budgets or the innovation activities inside of provider systems less than a decade ago, you would see what we would categorize as a lot of physician-centric innovation. It was about process improvement. It was about implementing EHRs. It was about gathering clinical data. It was about how we empowered physicians to do different things to patients, to do them more efficiently, to do them in a leaner way, to change the process, to change the systems, to change the culture, to look at how we got reimbursed differently. All really important stuff, all things that are kind of groundwork for building a modern healthcare system, but don't necessarily reflect a careful scrutiny of how consumers want to receive care and how we can serve them best. The bar is now higher. We're now moving into a world where innovation is fundamentally patient-centric, and it has to be. Value-based healthcare is a patient-centric activity, and it's about engaging people where they want, how they want, at a price point they can afford, where outcomes are measured on whether the patient feels healthier, feels engaged, feels compelled by the kind of care they can receive, and not just some sort of hard, cold metrics that we've been used to. And I think that requires a very different kind of partnership. One of the things I'm excited to talk about today is, the left-hand side of this, physician-centric innovation. You could be a fortress health system. You could be a health system that was primarily focused on owning assets and changing internally. Patient-centric innovation is much more about partnership and much more about being in an information business and working with the best in the industry, whether you own it or not. The implication of this is that innovation has to involve evolving the core business. And so a lot of what innovation has been historically has been the left-hand side of this chart. It's been clinical programs, evidence-based medicine, process improvement, transitions in care, post-discharge program. A lot of what I think especially we're going to hear about from Frank and from Jan is that evolving the business across the value chain now is really about creating a holistic care model and about improving every patient interaction, proactively managing patients, having patients engage with you as consumers in the way they want, staff who engage. And some of this is, high-tech and interesting. It's apps and it's social and it's mobile. But some of this is low-tech culture change and different ways of engaging with people. And that, I think there's a lot of debate inside of systems about, just like we talk about living in the fee-for-value world and the fee-for-service world, how do you live in the focus on efficiency and bottom-line world and focus on providing high-quality touch points for every patient? And it'll be a great discussion today. What that implies is that the innovation agenda for health systems has to focus on a whole new set of hassles. When we within Oliver Wyman do research about consumer hassles and draw the hassle map, we find 5 great hassles that all of our guests today have already mentioned as being the real focus of innovation activity. How do you provide higher quality care, more affordable care, more convenient and accessible care? How do you engage and reward people to do the right things? And how do you hold the right organizations and the right individuals accountable as a consumer for understanding the entire healthcare picture? And what we find is that this really is what underpins the shift to value. These are the kind of microeconomics, the micro factors of the shift to value, and really a focus of innovation. So what isn't innovation? When I have conversations with healthcare executives who think about innovation, there's often a lot of myths out there. That it's the result of a lot of kind of head scratching and randomness and creative flashing insights. That innovation is always good. I hope some of the stories we'll hear today will be about failure, because there's a lot of failure involved in innovation, and innovative organizations fail and fail regularly, but they fail in safe ways. That it has to sit in an R&D kind of department or an innovation department, a group of people who spend a lot of time with either beakers or Post-it notes, depending on what kind of innovation it is. That's not what innovation really looks like and feels like. Innovation is doing. Innovation is out, and it's in front of patients, in front of physicians. That it comes exclusively from the inside. There's a lot of, we want to be an innovative organization. or we want to have an innovative culture, and partners like the ones we have today are really critical. Industry organizations like what Jeff will talk about are really critical to making innovation happen. And so hopefully we can dispel some of these myths today and make it clear that innovation is high-tech and low-tech. It's inside and outside. It's success and failure, but fundamentally innovation is about doing and getting out there and changing the way you deliver care. And then I'll kick off our first set of questions with just a set of observations that incumbent provider systems and innovators working together is really hard. And we'll hear stories today. I think all of those on the phone who are joining us can tell stories or have lived stories about why this is hard. We spend a lot of times with health systems that say, I just want to find the right innovator. I just want to find the right thing to plug in, and I can't figure it out. And we spend a lot of time with innovators who say, if only I could find the right entry point to that big health system, if only somebody understood what I was doing, would listen to me, would take my call. And that's fundamentally because these organizations are built to do different things. Big incumbent health systems are designed not in a derogatory way, but to be slow moving, to be risk averse. We come from a culture of not wanting to kill people, and where we value stability over growth, where we pay close attention to the bottom line because we operate on slim margins, and when we do something, we need to do it at scale. That means we have a slow product life cycle. We move in a very stable way, and we tend to get pretty bureaucratic. Innovators are designed to be exactly the opposite. They're designed to test and fail and test and fail, less concerned about stability, more concerned about growth, and really have responsibility and rewards aligned around innovation. And so I may have V4 or V5 of something by the time a health system I engaged in a conversation with about V1 is ready to take my call. And so a lot of, and I think it'll lead to our first question, a lot of the tension in how to make this work is there are health systems that are eager to engage and support their patients and physicians in a new way, but have cultures that are designed for a different set of incentives. And there are innovators that have those solutions and can make a real difference in the way that care is delivered, but need to learn how to speak and engage with health systems. And I think there's a big opportunity for all of us to kind of crack that nut and really make a difference in the system. And so with that, I'll let the discussion begin.
Well, thank you. We're now going to turn to the discussion elements, and with respect to each question, we'll start with one of the presenters, and then others will sort of join into the discussion. And I thought the first question we would get is sort of the highlights of the whole thing. Just what are the innovations that you think are most likely to make a difference in how healthcare is delivered today? And Dr. Berger, I think we'll start with your take on that.
So thank you. Like all the questions we're going to have coming up, there is no easy answer. But I would say in innovations, we are not, the healthcare industry in general and providers in specific are not risk takers. So finding those places, those innovations that can be wins, that are not totally disruptive, that fit in aligned goals are really going to be those we have to think of first. It may not get us all that way there. It's a crawl, walk, run. I've worked with a number of organizations where e-prescribing in the past was a great example. It made total sense to me, but it totally disrupted the physician flow. So finding those things where both the physician and the consumer, who is their client, intersect and make it easier or a way to be more successful are going to be those innovations where people are going to find innovation doesn't hurt, it's a little less scary, and hey, we can do it. Because failure is not something providers, whether it's killing the patient or you look at what those of us who went through medical school, nursing school, whatever the provider is, we were trained to succeed and compete. So innovators can be fast failures. Providers cannot. It's just not in our DNA. Those are my initial thoughts.
Okay. Others want to talk about what they see as the most likely to make a difference. The Oscar Awards.
Well, this is Frank. I'll just comment that for all of the innovations I've worked on in healthcare, I think when they're linked to real financial issues, real business issues, I think it becomes a lot easier to create urgency and break down barriers. So right now, because there is a feeling that staying in fee-for-service and doing exactly what you've been doing will lead you to a very difficult financial situation over time, given the change in mix of patients to Medicare and Medicaid and exchanges, as well as just general reimbursement pressure. I think that theme really helps to frame why, even if you were slow moving in the past, why beginning to move with some urgency is going to be critical. If you want to maintain your financial performance, if you want to be able to fund your mission, that you actually are going to really have to try to adopt some new ways of doing things. And I think that's pretty critical if you're going to get people to really act and try new things.
Okay. Comments from others? I guess one of the... Go ahead.
Yeah, this is Sanjay. I think I agree with everything that's been said. I really agree with that concept that in order to drive this and to be effective, it's got to be tied to some type of financial reward. I think practically speaking, though, if you look at where things are going to actually make a difference and how healthcare is actually being delivered, we've got to be very, very cognizant of the processes that actually it takes to run these programs, right? These are hard work to actually manage a value-based risk contract. A lot of blocking and tackling, a lot of work that's being devolved down to the level of individual providers. So when I think about how we really transform healthcare, it's how can we really take things out of the front of their brains so that it's sort of a thing they have to think about all the time versus how can we make it just sort of part of the culture, part of what happens, part of what everyone in the healthcare enterprise is sort of doing just by rote and automatically. So those are the types of innovations that we're hungry for because we know that there's so many whiz-bang sort of pretty things that are out there that seem like a great idea, but all they're doing is sort of adding steps to the process or adding things for other people to think about as opposed to taking things away from what they have to think about so they can focus on sort of the difficult, the non-routine stuff. And what we really want is an ability to sort of make sure that all of our providers, all of our patients are able to sort of get the high quality care without having to sort of actively think about it all the time. So in terms of what will make the most difference is anything that will really change the paradigm in terms of what people have to think about every day.
So it's kind of thought process oriented as opposed to something more, if you will, mechanical that would really make the difference. And as I understand it, we have to find a way to get out of the existing sort of contracting, and I use that both legally and non-legally environment, which weds us to certain types of products and processes. Let me kind of for the moment move on to what our next item is, which I warned everybody out at the beginning, which was the CLE issue. And let me just say the first code is 2C071. If anybody needs that, 2C071. All right, with that, let me move on to our next discussion item is, given this framework, what are the aspects of the provider or provider delivery system that sort of makes one ready for innovation? It's not something you do tomorrow, but you got to get ready for it. And what's getting the providers interested in innovation? Some of them, and others just kind of staying on the sidelines. And Frank, let me start with you.
Yeah, I think at one level it is true that provider organizations, may be slower moving in certain aspects of what they do. But I think most organizations, they have innovated in certain areas. They've brought in new clinical technologies. They've developed new clinical programs. They've moved into new business areas. So the first thing is, likely somewhere in the organization there is some DNA around, driving new ways of doing things. And I think building upon that and seizing upon that to say, God, how do we take some of what we've done in the past and begin to scale that and do that more boldly. And as I said before, I really believe that in almost all industries, you need to build a case for innovation. What's the business rationale? In the case of healthcare, what's the clinical vision? How does this tie back to our mission? But really a clear sense of why are we doing this? How does it tie to financials, et cetera? And then it really takes leadership. And I would say the organizations where I tend to see the most change are the ones that have an executive team that's bought in. They really have a vision for where they're going. They're willing to communicate and sort of educate people on why the change is happening and to get regularly out in front of it and really build the case. And then to boil that down, I think, into a clear strategy, clear objectives, and pacing. Because what we tend to see in some organizations is they may have a goal for innovating, but when you look at progress, they're not really setting a near-term set of metrics to know how they're doing and to really ultimately drive results. And then lastly, and I think people reference this, in almost all companies, the core tends to kill the new. It's just a natural thing that happens. People don't like the new thing costs money, and the people who've been running the core tend to be very different thinkers than maybe the entrepreneurial people you have working on the more innovative initiatives. And so how do you get the right people in seat, the right structure, and then ultimately really drive accountability through that structure? And I think that's critical. It's actually one of the reasons why we spun Evolent out as a new company out of the advisory board, because we felt like if we tried to do it from within, it'd be very hard to move with the level of pace and innovation that we would want. And then if you then translate that into the market, the providers that are most interested in moving, as I said, are one, where you have bold visionary leaders, two, where there's a clear business strategic case that's been built for why they want to move, and then where there's actually been market disruption. So you've actually been tiered out of a network. A competitor has made a move that's somewhat threatening. So I would say in the more competitive markets where the change that's coming isn't theoretical but very real, you'll tend to see a lot of those players move more aggressively. I mean, Boston's a great example, of a market where a lot of players are moving, with Steward being one of the boldest in terms of what they're ultimately doing. And then that ultimately creates action. And then just to finish, I think those on the sidelines generally are not looking comprehensively at, a 4 or 5 year vision of where things are going. So they're a little more near term in their focus. Sometimes they don't have the people with expertise internally, so therefore it's hard to really know what they should do. And then, of course, they're quite worried about trying to live in two worlds, one that would impact their fee-for-service business and the way that they've operated historically, and that really threatens wanting to try anything new and potentially have bad financial performance and operational risk. So that's where we tend to see people staying on the sidelines and being a lot more cautious.
Let me just interject for a moment. I think we missed some of the code for a number of folks. So let me just sort of hit that one again. It's 2C as in cow 071. 2C071. Okay. That's a great.
Mark, it's Sam. I just say I agree with Frank. I mean, I think it's very hard sometimes to build wholly new innovative businesses on the inside, particularly as they start to get successful. And so, thinking about the innovation strategy for providers as we spend time with systems is really a multi-pronged thing. There may be a diversification strategy or an investment strategy that's about to taking strategic positions in innovators. That's one thing. Changing the core business and innovative ways of doing business and having partnerships baked in there, that's one thing. And then you very well may, there's a big trend in org design we're seeing for providers of actually having a separate CEO of new disruptive businesses who doesn't have to deal with the core business. And that might be, anything from dealing with, designing a new Medicaid business model to, delivering concierge care, whatever it might be, depending on the market. But, really being willing to make the commitment and section that out is hugely important.
I guess since we've heard Steward mentioned by Frank, I guess Dr. Shetty, one of the questions that seems to come up in my mind is, do you really need a skunk works? Does it have to be outside the organization or outside the existing structure, or just what is the optimal structure to try to decide that you're ready for innovation?
Yeah, I think we do a lot on our own. I mean, what I think we've discovered over time is that as you get more and more experience with these value-based contracts, we begin to understand sort of what the issues are. And then we start to go look for partners. And sometimes there just isn't anyone who's kind of gotten to where the conclusion that we've gotten to, that we need to try to approach a problem in a certain way. I do think, though, that many of the folks that we talk to really have thought carefully about the issues that we're dealing with. And we're dealing now with a great small company that's thinking about behavioral health, not an area that we had much time to think about, because we sort of started our prioritization with sort of some of the biggest chronic diseases and sort of started to work our way down. Now having a partner who's really thought very hard about a space that was a little bit outside of our wheelhouse with regards to the accountable care contracts that we have has been really helpful. So I do think that the mixed approach is going to be useful. I think for folks that are looking to catch up or who haven't been in this world for as long, I think having these outside partners who have done a lot of the work, that have used laboratories in places like Steward to improve and optimize their products, for them it'll be a much more useful strategy to work with an outside person, because it'll help accelerate their timelines.
This is Jan. I think the other thing that's kind of interesting, and I think Steward is a good example, we all joke that healthcare is local. And I think the external environment also can create a need. So whether the external environment is a state or a region and that issue, whether it is the employers that are the client and that environment, or whether it's the consumers in a certain area that you're looking to work with. I think that we need to look at all those environmental factors as we say what makes somebody ready for innovation. Healthcare is slow, and I am quoting an Oliver Wyman article recently that everything in healthcare is slow. None of us like change, but impetus, whether it's internal or external, really makes somebody and an organization or a person ready for innovation.
And Mark, I'd just like to add on to emphasize, I think what's been inferred and said in all of the comments to date on this question is the need to assess the core competencies for your ability to innovate. I think the panel today really are dealing with people who are on the cutting edge of innovation, have been thinking a lot about these issues. I think the experience you see with the Department of Health and Human Services Healthcare Payment Learning and Action Network is you have people who are coming to sessions now to learn and to understand, and for them to have a willingness to get into the game is important, but them to be able to assess their ability to do so, know their weaknesses, what they may need to work on before they can jump off is really important for those that aren't necessarily in the early adopter category. And you are seeing, products kind of pop up that really are assessment tools to make sure that someone who's looking to enter the space can have an assessment from, an objective assessment from those who have been there, have learned from their experiences, challenges, opportunities to know if, in fact, they're ready to go. I think the one thing our task force membership has recognized is the reality is not everyone's going to be able to do it, and not everyone's going to make it. And it's a very dynamic marketplace in that regard. And while it's really important to get ahead of it, there is no one-size-fits-all model. And so you need to be able to assess your competencies, where you need to improve, but also what improvement is important for the community and the patient population you serve.
Thanks, Jeff. I think one of the challenges that is out there to the assessment process is how do you go about getting an objective assessment so that you can make informed decisions. It kind of leaks us into the next question about, just how do you overcome the key barriers to entry we've been talking about. Sam, what are your thoughts?
Yeah, I think part of this, and I'd be curious actually to hear Sanjay's take as well, is that providers tend to see, there's a ton of innovators out there. None of them seems like a perfect fit, and they feel like there's, I think, a lot of sort of solutions out there in search of a problem. And one of the challenges here is that innovators need guidance and focus on starting with their own customer in mind, and if their partner is the provider system in this case, really what are the challenges that are the top 2 or 3 challenges that that provider system is looking to address. It may be the same solution across provider systems, but a provider system that's in a market that's moving to value very rapidly and doesn't know how to manage that, and is really focused on building some core population management capabilities, is in a very different place than a provider system where their market may be moving more slowly to value, but they're needing to experiment around bundled payments or retail partnerships or whatever that might be. All of that is about providing a holistic consumer experience, but the reality is, most systems don't have somebody whose title is, Chief of Holistic Consumer Experience. And so I think a big piece of it is translating the solution into really what is a particular system's problem, what are the 2 or 3 things that are the existential issues they're going to have to deal with over the next couple of years, and how does your solution fit into that?
Yeah, and this is Sanjay. I agree exactly with what was just said. I mean, especially with that idea of the solutions in search of a problem. When I think about one key barrier to entry, is that many of the vendors that we see, and boy, oh boy, do we see a lot of them in terms of people who promise that they have the answer to all of our ills, is that in their minds, their solution is it. They come in, they drop off the solution, and they walk away. And they haven't really contemplated the fact that for so many of these changes, it does require behind that a whole lot of support, right? It requires help with the cultural transformation. It requires constant modification to understand where as the provider continues to evolve, the solutions that it needs will continue to evolve. And so for me, sort of the easiest way for sort of the innovators to cross that barrier to entry is to frame it in terms of a partnership, and to frame it in terms of we are going to grow this together, and that we understand that your needs right now are going to be different than what you have in the future, and that our solution may serve some of your needs, but there are pieces that we don't address yet, but we will address because we recognize it's sort of crucial for you to have this piece addressed in order for this to be a workable solution. So for me, one of the key things is that it has to be a vendor or an innovator who's willing to work with us, to partner with us, and to really think of this as a we will grow together type of relationship.
Let me ask Frank and Jan initially, when you're talking about, we need someone to work with us and partner with us, we've seen chief experience officers sort of come into the vogue, chief compliance officers come in vogue with respect to what systems do. Do we need a chief innovation officer to canvas, look for objective assessments, figure out where innovation fits into the system, or by putting it out there, does that segregate them too far and actually make it harder? Or what's the right door?
This is Jan. I think part of it depends on the culture in the organization. And sometimes if you have a chief innovation officer, if you will, and I've carried that title, so I know the good and the bad of that. And sometimes I'm segmented out and there's no buy-in. So it really depends on the organization. It also depends on the comment that was just made around having a solution and having to search out the problem. And I think this is one of the things that's kind of interesting as you look at chief consumer or patient experience officers. One of the challenges that I would make to all of us is that we think we know what the problem was, and we need to ask. In the consumer space, as physicians and providers, we think we know what the consumer wants. I would argue, I was really surprised, we really don't. And so make sure you're really solving the problem that is out there and not the problem internally that you think is the problem. I would say the most important tool we have in innovation is listening in our ears. And we're not always so good at that. So if that's going to be what the innovation officer is going to do, is gain that knowledge, gain that research, bring that back in and say, here's the problem we really have, especially in a consumer-based and value-based world. I think, is it a consumer-based and consumer-centric? Is it a provider-based and a provider-centric? I still think we've got to figure all that out.
Okay.
And this is Frank. I'll just add a quick perspective on that. You think about the subject of the call, which is really this sort of movement to value. I mean, this isn't evaluation of a new technology or just a new analytics platform. It is really the launch of an entirely new business and operating model. If you think about where Sanjay and Stuart are going, it is transforming their entire business.
Yep.
The way they get paid, the way they operate, the way those things integrate together. And I actually think you can do it a disservice if you sort of say, look, I'm going to have someone who's an expert in just evaluating new innovations sort of run it. That's not really what it is. I mean, you really would want whoever is the general manager of this new business and or the CEO or senior executive team highly engaged and involved. And it becomes an integrated set of decisions. And I think one of the problems we see sometimes is someone over on one side of the organization has been tasked with purchasing a new analytics tool. Someone else is involved in something totally different. And in reality, having one quarterback who's very senior, who's really viewing this as, wait, this is going to be in some cases a $500 million, billion-dollar business that we're launching, and we're going to treat it as such and have a senior executive who's driving it and driving it in an integrated way. I love it when I see the CEO taking that role. In some places, they don't, and they don't have the time for various reasons, but I'd love to see a C-suite level of executive who's really a general manager driving it.
Our next thought, kind of again, leads from both the past comments and moving forward. Does the use of innovators who are outside the existing structures result in reduced costs or simply shift the costs so less is spent on the traditional side and more is spent in innovation and technology kind of on the outside? And I know, Jeff, you've been kind of studying for a number of years just how a lot of these systems, principally hospital-based systems, actually look at change, and maybe you could offer some thoughts about, just how does this work, and is it realistic, or how does one become realistic about these kinds of things?
Well, I think it's hard to have a one answer to this. I really think in many respects we hear that the jury is still out, on this question. For an answer, there's still a lot of testing going on. Healthcare is local. Different things work in different markets. And it's important to be sure that things are fully evaluated. I think there is an increasing amount of commentary on this issue in the market, but I think it's a be careful right now. There may be conclusions that can be reached in particular markets, but to the extent then they're trying to be broadly applied, I think that's something that we should be cautious about doing. It's clear, and I think it's been said in response to some of the earlier questions. I mean, organizations who are willing to innovate just may not have the expertise and the experience to do so. And so while maybe it is an added cost to have an outside entity come in, it may very well be cost effective in the long run to have that entity come in, train, educate, teach an organization that needs to change and wants to change but doesn't have the expertise. So I think you need to almost take the long view over it. I think it's interesting when you look in the public space and you look at what Medicare is doing, on their bundling programs. They have the Bundled Payment Care Improvement Initiative. They also have the Comprehensive Joint Replacement Initiative. They both kind of treat the outside innovator a little bit differently. One being very friendly, one not so much. So I think it is still important that from a macro level, we are at a testing phase and evaluation phase, and it's easy to jump to conclusions about the impact on the cost of care, but I think we just need to be patient and evaluate those as everything matures.
So, Sam, let me ask you, this is a kind of evaluation, obviously, that you and your team does. When you look at the is it worth it question, what is it, and how long sort of does it take to find out the answer to that question?
Yeah, so I think this draws on a lot of the themes of the conversation we've already had, which is, first of all, if you're asking the is it worth it question, it has to be a real business question. There has to be a P&L owner, a general manager who thinks that this is core to the business. Second, you have to have evolved the commercial model so that you're getting paid for the right kind of thing. And so if I'm doing innovation to reduce cost of care, that's a community service initiative unless I'm in a value-based payment arrangement. And I better have a reimbursement strategy that is aligned with my innovation strategy, or otherwise innovation is an initiative that's outside of the core business and isn't going to get the attention. Assuming I've got that, assuming I've got a business owner who feels like this innovation is a core part of his or her own business, and we've got a commercial model that supports the kind of innovation we're driving, typically it's a 3-year road. In really good innovations, you lose money on them the first year because you've got a lot to learn. You figure it out so you break even in the second year, and in the third year you start to see some positive ROI, and we've got to get comfortable with that. Particularly for providers, there's a lot less turnover in patients than there is for health plans with the annual enrollment for members, and so they have the opportunity to do that. The other piece I would say is we've got to have a measure that says, are we doing the right thing by the patient and not for the protection of our physicians or other clinicians? And we see this in alternate sites of care, and particularly retail care all the time, where a system wants to do the right thing. They want to have a partnership with a new kind of care provider. Say it's a retail clinic. That retail clinic can deliver the visit for $40, $50, $60, but they have primary care physicians who call that competition. And the reality is, if I'm a patient and I can get primary care for $40 and not $130, that's good for me, and that's a measure of innovation success. And it's a change management challenge to bring the physicians along. But we got to stop measuring success as whether we paid our physicians enough.
Now, Frank, does that sound right to you? 3 years, need a commercial strategy before you get started? Is that the way you see it?
Absolutely. I think one of the pitfalls that I see in a lot of discussions is a singular focus on clinical and analytics and redesign work on that side, but not stepping back and saying, wait a minute, we actually have to have enough revenue under performance-based arrangements to make the whole strategy work. One, to get the mind share of the physicians, but two, to tilt the balance enough that it's financially meaningful for the health system. So I think that aspect is critical. I think it's a multi-year process, and agree completely that it needs a general manager and someone truly running it like a business, and frankly with different incentives than the core business, and acknowledge that it is a startup and needs to be thought of as such. But I agree completely with the comments.
This is Jan. I think the interesting thing here that an undercurrent is people understanding the difference between fast failure and patience. And I don't mean patience like a person coming into the office. I mean like giving something time. So the 3-year model, which I absolutely agree with, is one where if your other outcomes besides financial are being met, giving something the time to evolve and to change is different than something really bad came out of this, non-financial in the first year, and you need to put a stop and fail fast. So I would, for anybody on the phone who's listening, I want us to make sure that we are delineating fast failure from having the patience for innovation to evolve.
Let's move on to our next question. I mean, key to the healthcare system, the physicians. Has physician buy-in been a problem? Will it be a problem? How do we minimize it as a problem? Or is it really an opportunity that needs to be cultivated? And Jan, maybe you want to start with this one.
Sure. Has physician buy-in been a problem? In my different roles through the different years, sometimes yes and sometimes no. What I have found most recently, and especially with my work with Quantum, is that it hasn't been mostly a problem, and that's somewhat unique. What we have done is we have taken those things, and as I said earlier, the research showed that 95% of consumer hassles, frustration, confusion was outside of the actual care management piece. And as we go in and work with physicians, we say if we take these things, such as pre-authorization and much of the, quote, insurance stuff, off your plate, would that make your job easier? And so for us, it has not been, the buy-in has not been a problem because they have a very real problem that they don't want to deal with that is very different than what they hope their goal is. And, by the way, makes them more financially successful besides clinically and quality successful. So in our case, once we talk to them and explain we're not getting in the middle of things, we have found the buy-in to be extraordinary. And this is the first time in my 35-year career of being an innovator that I've had that. But I think it is a unique situation.
Maybe you could give us a couple of examples of sort of specific things where the buy-in to innovation was extraordinary.
Well, I think with the care coordination and navigation, it's been great. Where I have gotten great pushback in my career, whereas the other would be disease and care management. When I led, and that's what I did, the providers felt we were taking what is their role, and we were becoming a middleman that they thought was not necessary, not good for themselves, and not good for the patient. E-prescribing initially, why did they push back? Because it totally changed their day-to-day work and actually made things slower and harder for them initially. I think we saw that initially with electronic medical records. But if there is something they know isn't in their day-to-day preferred pathway, paperwork, pre-certifications, understanding networks and their patients' insurance, most providers don't feel that that's their goal. And so that's why buy-in from them in this case has been so successful. And I think that can be a pattern from innovators to listen again to what is the problems that the providers have to hope to get to the new goals, especially in this consumer-based world where more and more the consumer is going to get to choose where they get their care and who they get it from.
Dr. Shetty, you've been running a network of physicians. Interested in your take on this one.
Yeah, so I agree with a lot of what Jan said. I think a couple of other points that I'd raise. First, their willingness to accept innovation, like she said, I think ties in directly to sort of how will it impact them on a day-to-day basis. There have been a few innovations that we've been able to put in that actually addressed some of their biggest pain points every day. Sort of how quickly can you make a referral? How quickly can I find that the provider? How quickly can I refer into care management? If you can make it easier, they're much more likely to adopt. That sort of goes without saying. The other is that if we're able to tie it pretty clearly to a financial incentive, especially our private practice physicians, it starts to make sense to them. So some of the innovations have actually been to devote resources towards the private practice offices to help them succeed in some of these contracts and some of these programs, and to change the way that they're providing care. If we can make it really clear to them, one, that it's not all going to fall on their heads in terms of the added expense of doing more work in some ways that wouldn't ordinarily be needed in a fee-for-service model. Plus, if we're then able to add to that a financial benefit from success in these value-based programs, obviously that really helps us in terms of getting buy-in from the physicians. And I'll be honest with you, sometimes you even lay out those two steps, right? We'll actually make it easy for you to do, and we'll give you money to do it. And they're still resistant. And it's only sort of after the first or second year when they see their colleagues' scores going up, they see their colleagues' distribution checks going up, and they're kind of realize that, hey, my stubbornness around this really wasn't warranted, that then we get the buy-in. So for us, some of the key innovations from 2-3 years ago are really now beginning to pay fruit because it took a little while for some providers to change their old practice patterns.
So given how busy the providers hopefully are, when you want to approach them and sort of demonstrate the value, demonstrate how it works, I mean, what is it that you've been able to do to kind of work around that, A, resistance, B, scheduling problems, and C, the issue of it's going to cost me money just to give up the time to spend time with you? So are there some strategies that you've used to work that through?
Well, I mean, part of our strategy for engaging with the docs is just sort of a general engagement model around participation in the network. So we have a regular channel that we communicate through regular meetings, et cetera, that are sort of key to earning anything under our value-based distribution model. So that helps a lot because we kind of have them as a captive audience a certain amount of time every month. And so that's been helpful both across the employed and private practice docs. I think another key thing for us in terms of success in getting these to roll out is to be thoughtful about how we pilot things, where we pilot them, and with who. Because a lot of times, me saying that an innovation is good will go so far, but one of their colleagues in the trenches who they've known forever, who says it's the best thing ever, will really get them to buy in to a particular thing. So a lot of our network management really focuses on that grassroots level, on using innovation in targeted ways at the beginning to get us some promoters within the network who can then share the message with others.
Comments by others on this topic? Okay, on to our next question. How can innovators integrate or insulate themselves from these increasingly established patterns that develop at providers? So if you want to deal with an incumbent who has the EHR or platforms for care management or disease management, or an incumbent who uses sort of an old technology as opposed to a new technology, Frank, what are your thoughts about how you approach that?
Yeah, well, this is a real challenge. I would not want to be in a business that was trying to replace, a recent EHR investment. That would not be a good business to be in. It's simply difficult, right? If someone has just spent several $100 million on an investment, they generally don't want to go in a different direction. So I think there's a lot of things to keep in mind. One, viewing your service or technology as an enhancement so that you're going to get more out of an investment that they've already made. I think also recognizing, this is a subtle point really on the adoption side, but relationships matter. A lot of times you may have something that is very logical, it's clearly better, but you don't necessarily take into account that the people you're selling to actually have 20-year relationships with their EHR vendor or their GPO or people who've been there every day in and out, and there becomes, a really important thing to understand of how do you take the time to really build a relationship and confidence over time, because those are not easy relationships to replace. But I think, the previous comments were dead on in terms of the customer is always going to make a decision about, one, this is going to take up a lot of time and energy, mind share, it's a new thing to take the physicians, is it worth it? So how do I really understand the customer problem intimately? Everything about it, the knowledge of how they talk about it, how it impacts them, what the economic issues are related to the problem. And then how do I design a solution which clearly addresses the problem and it does so in a differentiated way? Our biggest obstacle in the 25 years I've been selling into provider organizations is, we're fine, we'll just do it ourselves, or we're just going to use our existing system. So you really have to bring it to life how your approach, your solution is truly different and how it's going to add significant incremental value, because most organizations are too busy. They have too many initiatives. Their IT staffs are busy, as an example, and so you really have to make it worth their while. So really doing a lot of work to educate them on the problem, show them research, best practice. Don't sell features and functionality. Sell around the problem that you're solving. And then a rigorous evaluation of seeing the product actually in action. If I sell it to Steward, is it really having the impact? How do we iterate to make it most effective? Because if I begin to have real results and case studies, then those are the best ways, again, to at least supplement an incumbent and bring a new innovation into an organization.
So, Sam, if you think about it, I'm an innovator. I've got the next best thing since buttered toast, and I want to get it purchased by somebody big, or maybe what I'm hearing is, do I start with somebody small, or who do I call? What do I do?
Yeah, first of all, you better be darn sure it works. But what they've done so far, and what innovators tell us is, they tend to find it really difficult to penetrate health systems. They find it really difficult to penetrate big health plans. And so they often start by going after employers, self-insured employers, because there's a lot more of them. There's a more limited number of buyers that they have to address. And if they can price it in a way that works for employers are willing to take more risks on that. I think that works for certain types of solutions at a relatively low price point and where a self-insured plan sponsor is willing to do it. But for others who don't, there's another angle, which is there are providers that are, take the EHRs, for example, that would be very happy to bring in modules and connections to those systems. And if you have an innovation that does that, that helps you get inside. But if you're truly, a provider-focused innovator that is trying to break in, it's an 18-month cycle, is what we see. And you have to understand the org chart of the organizations you're going after. You have to know not just the types of organizations who would buy it, but who within it would buy it. You may have to be willing to take strategic investment from that organization so that they'll give you a try. You may have to start with some smaller organizations, but make sure you structure that contract in such a way that you have a really well-articulated business case coming out of it so that you can share data. But it's not going to be the typical startup B2C sales cycle or even a non-healthcare enterprise B2B cycle. It's about an 18-month cycle, and you've got to build a business plan that allows for that.
Comments by others on this one? Who do you call? What do you do? How do you get in the door?
This is Jan. I agree with most of what was just said, and I want to reiterate, understanding the politics within the organization you're trying to sell into is really important today. And we've seen this in a number of ways. And so doing your homework, building the relationships and the time will hold you in very good stead. And being realistic, the 18-month sales cycle, understanding the organization and knowing their budget cycle can help a great deal as well.
It sounds like you need a survival strategy that funds what you're doing for at least 3 years. You need a targeted program in order to accomplish sort of that strategy around the particular innovation, and you need to be awfully careful about your target market, that you have the right focus with the right people that can actually make decisions, or you've wasted a lot of time and money. It's kind of what it feels like.
Well said.
Yeah. Are there some misconceptions about the ability to bring innovation into these systems, Jeff?
Well, I think there are. I think I probably would answer that from two different directions. I think first from a value-based care model. You definitely hear bandied about, whether there is a particular model, kind of the be-all, end-all model, whether it's a population-based health model, two-sided risk. I think that there's a lot of innovation in the marketplace for a reason, because I don't think there is really a one-size-fits-all when it comes to a model. So to the extent an innovator is pushing a particular model, that may not be the solution for a particular market. I think we've heard that from other panelists. And I think that's also key, and I piggyback on what Frank said with regard to the last question. I think with regard to an innovator's product, it's critical that that be positioned as kind of a starting point and making sure that the basic infrastructure is there to help a particular organization innovate, but recognizing that the innovation itself may require some customization, some highlighting certain capacities over others, and those really need to be responsive to the market. And the one thing I'll say I've heard as part of our conversation here all along is, and Jan just alluded to this, it's really important that you look at your constituency as you plan for innovation to include the large employers in your community, the mid-sized employers, well-formed patient groups that can give you feedback. They may not be a barrier to entry, but if not properly addressed, they certainly can be a barrier to success. And so to the extent that you are making a significant amount of investment, having that market analysis to include what the employers in your community really feel is important, I think is a critical step. And we've heard of some examples within our task force where the fact that some of that front-end engagement did not take place really required some retracing of footsteps at considerable expense and time delay. So I think the one-size-fits-all and the idea that some of the products are actually just plug and play may be misconceptions.
Let me ask others, I mean, are there some misconceptions that you've had to overcome? And if so, how did you do it when you wanted to bring something new into the system? Sounds like we've had a great deal of success and not enough failure, as some might say. Or it just didn't get there. I mean, the trouble is with the sales cycle and so forth, you really have to have the misconception is it's going to be easy. Misconception is that you have been able to save money when in fact it either was so small or it didn't have a reimbursement strategy around it that those who were buying just didn't have the ability to marshal enough resources to make that kind of decision. It's been one of the challenges we've seen in a number of our clients.
Yeah, I think, Mark, it's Sam. I mean, the other thing I would say is that as much as we've talked about there being a clear business case and there a need for real measures, assuming that the financial ROI is all that matters, I think can trip up some of those who are trying to drive innovation. As Sanjay hit on particularly, the change management with physicians, as Jan was talking about, the politics inside the organization. You have to be able, I think, to make a case that says, yes, there's a clear financial metric, yes, there's a clear outcomes metric, but also we've got a plan that makes this easy in the first year. So we've got a plan that's going to bring along the right people. We've got a group of champions internally who are actually going to practice differently, even if we don't have all the physicians on board and are willing to tell those stories. I think there is a misconception that if the technology plugs in and the business case makes sense, that the world will be the path to your door. And given the way systems work, that's not often what happens.
That's for sure.
The other thing I was going to quickly say is that I think one of the biggest thing innovative service providers face is the customer feeling like they're doing just fine. Everything's okay. And so the more you can demonstrate what best practice is, that's when you get a CEO's attention to say, hey, you might think you're doing fine, but let me tell you what the best organizations are doing and the level of results that they're achieving and why that level of result translates into massive strategic and financial benefit. So the more I think, and you have to be honest, I mean, the more it can be truly metrics driven so that if a CFO were to break it apart, it felt very real. That's when someone says, well, wow, I thought we were good, but maybe there really is an opportunity to improve, and this is pretty important.
So Frank, is it you should get ready for a kind of a Shark Tank presentation at some point? That you get your 5 minutes of glory to say you need to invest in me because here it is, here's how it works, taste it, feel it, smell it, or is it really a much longer process? I mean, where is the target there?
Oh, I think it's a much longer process. And ideally, sometimes you don't have the luxury of investing in the resources, but if you can get the prospective client to share data, and to be willing to go through some diagnostic process, it is so much more effective to show someone the opportunity, in their specific organization versus a generic set of benchmarks. And that usually, it takes time, and there's multiple constituencies, and as people referenced earlier, politics in the organization. Usually, that's going to take some time. It's not your 10-minute elevator pitch.
Let me announce for the folks interested in CLE the second code that one would put in and submit. It's L as in Laura 5, M as in Mark, T as in Tom, H as in Heck. L5MTH. L5MTH. We go on to our next question for discussion. So you're down the road. Where does it fall apart? You started using it. When are you too far in? When are you not far enough in enough? How does one evaluate it once you've gone down that road? Jan, your take.
Well, I think it comes back, first of all, to the comment about fast failure versus having patience and having landmarks along the way. And the integration and the implementation is very, very important. I also think the comment that was made earlier, make sure your innovation works in some way, because if they see failure very quickly, they're going to stop. So I think that those are a couple of the things. I think when we ask providers to do something that is an unnatural act, and I think several of us have talked about this also already today, that's one of the places it falls apart. So finding champions, understanding the system, understanding the potential pitfalls. You're going to have pitfalls. Understanding those as much as you can up front and being prepared for them, very, very important to have. And again, to make sure that it's not just one person within an organization who is your champion, because healthcare is very fluid today, and people leave organizations. And so if you only have one champion, and your champion is walking out the door, often your innovation walks out the door as well, because you don't have the other champions there. So I would say those are several of the areas. The last place is thinking you're solving a problem that is the wrong problem. So understanding, and it comes back to a lot of what we do is the intersection between the provider systems or the physician as part of a provider system and the consumer. And so everybody's got to agree the problem that is being solved for, because otherwise the innovation may fail at that point.
Let me kind of turn the question a little bit for other members on the panel in the sense of you've made the decision to move forward. I guess the question is, what are the signs that it's time to pull the plug, and how would you do it, or how have you done it? Let me ask if other members of the panel might address, when do you pull the plug? How do you determine when to do that?
So this is Sanjay. I think when we've been through this process before and we have pulled the plug on things in the past, what it often ends up happening is that you realize, I think people get very worried about sort of all the sunk costs that they put into something. They worry about all of the manpower that's been put into a product or an innovation that you're about to sort of try to bring more broadly into the organization. And it's that recognition that, you know what, even if we get this all right, it's not going to be doing what we thought it was going to be doing, this product is not as it was sold. We are not going to have the innovation or the transformation that was originally promised. So even though I feel really bad about the last 6 months of time that a lot of really good staff have spent to try to get this to where we want it to be, even if we spend another 2 months on it, it's not going to get what we want, and we better just pull the plug. So for us, that decision point it's very difficult because of all of the blood, sweat, and tears that have been poured into an idea or a project or a product along the way. But it's that recognition that even if it seems like things aren't tracking the way we thought they would originally. So that's what's happened in our own organization, where we've sort of had taken that step back and said, there are better ways for us to do this, and we need to drop what we're working on right now.
Okay. Before anyone else weighs in, let me go back and make sure we got the codes right again. Putting that slide back up on the screen, the number L5MTH. And let me give everyone a few seconds to get that right, enter that, and submit it. L5MTH. While we're doing that, let me ask, anyone else want to take that on? When do you pull the plug? Yep. No takers. So let me go to the next one, which is kind of related, which is what do you do to prevent picking the wrong innovation, making a mistake? Frank, what's your take on this one?
Well, I'm guessing this is from the health system perspective, and if I'm an organization selling in, how do I recognize that I'm picking the right area and not the wrong one? And from my perspective, we've always tried to be very data driven in what we do. So this would be the organization selling, as well as maybe even the organization putting the innovation in place, and sort of rigorously testing, doing it with objective sources. So making sure you have some eyes on it that aren't necessarily invested, in the specific initiative. That going into it, you've set a basic set of objectives which says, look, we want to achieve sort of this minimum benefit, so that you're holding yourself honest and accountable as you move through the process. I think doing your best constantly to iterate and learn. Almost every innovation or even new business ends up being different than what somebody originally thought was going to be the impact or the reason for doing it. And so, you're taking the data in, you're reacting to it, you're changing what you're doing based on that. And then there's a moment where you're very honest and saying, look, we thought that it was going to have this impact, that it was going to have this level of interest in the market. We haven't cleared, the basic minimums that we've put in place, and, we need to move on to another area, or we need to try something, very, very different, but there's time to pull up, because I do think you can get killed, and I've been guilty of this at times, of just, you believe in something, you continue to push it through, and it just isn't having the impact that you expected.
Thoughts from our other panelists? How do you prevent sort of the wrong thing going down the wrong road? Sam, your take on it?
Yeah, when we work with clients, and in my experience, it's about knowing what your priorities are and what problem you're trying to solve before you move forward with this particular partner or a particular vendor. And I think, Sanjay addressed this well, which is if you're committed that you're moving to value, if you know your biggest challenge, for example, is reimbursement, and you have very specific targets around that, you've diagnosed the problems that need to be solved, it then lowers the stakes on the particular partner you've chosen. I think where we see systems that want to be innovative go wrong is they start with having got a really interesting pitch, but it's not aligned with the strategy that they actually have. or they start with, I want to work with X company, and then they kind of back engineer into what problem am I trying to solve. If you start with understanding the problem, what are the leverage points for the strategy you're trying to develop? What are the points that are going to make a real difference in your business outcomes? The worst you're going to do is sign a partnership that might not be the right one in 2 or 3 years, but you've learned a lot and you can swap that out. And that's really different than having engaged with a particular type of partner when you should have been going the other direction.
Comments by any of our panelists on that one?
No, I agree with all that's been said, Mark. I would just add again, reiterate a theme here is, again, the front-end engagement of a wide stakeholder organization, a wide stakeholder community to have input to the decision-making. Providers in particular shouldn't view the patient engagement as kind of a piece that happens later. To the extent you can engage the community, the employers, you can at least get as much information as possible to make a proper choice.
Jan, let me ask you in terms of innovation, how do you engage the consumer as part of the decision-making process by the provider side of the house on these things?
I think there's both formal and informal ways to do that. But asking the questions around the outcomes you think you're looking for as a provider, and asking, are those outcomes important to the consumer? Because, again, healthcare is an unchosen journey. None of us put on our list on any given day have a healthcare problem or even think about health. It's not like going to the flower shop. And I sound silly in saying that. But I think both formally and informally, seeing if, A, the innovation matters to the consumer, if it is bringing the consumer into the fold. We make a lot of assumptions. We really do, on behalf of the consumer. And so I would argue that whoever is making the decision, whether it is a chief innovation officer or somebody in charge or a committee, that there be an active process of asking the consumer.
So
and it is not something that is often done.
Kind of another important piece of the overall puzzle, realizing who all is in the process and how to appropriately solicit their input. Again, obviously keeping full cognizance of issues related to HIPAA we have to deal with daily in this arena, as well as all of the appropriate rules about physician engagement.
Absolutely. If you look at, we tend to be a bit insular in that we don't look at other industries. And if you look at the retail consumer industry, they've been very successful as they innovate by bringing the end user, the consumer, in very early. And I would argue we in healthcare can take a great lesson from the retail consumer industry in innovation.
That's a great thought to end on in terms of involving the ultimate consumer in the process. So let me just sort of end it on that. I want to thank everyone for participating in kind of a lively discussion with a lot of good points about how we deal with and address issues related to innovation. I guess as a last thing, for those who had problems with it, I do want to go all the way back to the CLE credit on the first part. I apologize for any issues. If you want to submit this was the first one, 2C071. So anyone that didn't get that, please put that in. And I want to thank everyone. Appreciated the opportunity to speak with you all and have our attendees listen, participate through questions, and I look forward to speaking with you on our next program. Have a good afternoon.